Good afternoon, good evening. Welcome to the ATS Assembly on Sleep and Respiratory Neurobiology Journal Club. And we're doing it in collaboration with the ATS Pediatric Assembly and the American Academy of Sleep Medicine, the ASM. Today, we will be discussing 3 articles regarding trends in melatonin use and misuse in the US. My name is Alex Gileres Hillel. I'm a member of the Journal Club subcommittee of the ATS Sleep and Respiratory Neurobiology Assembly, and I'm a physician at the Hadassah Medical Center in Jerusalem, Israel. Joining me in helping organizing this webinar is Dr. Sigwa, Associate Professor of Medicine from the Indiana University. And also, I would like to introduce our panelists in no particular order. Dr. Deirdre Conroy, Clinical Professor at the University of Michigan and a Director of Behavioral Sleep Medicine Program. Dr. Amy Licis, who's representing the ASM Public Safety Committee, and she's Associate Professor of Pediatric Neurology and Sleep Medicine at Washington University. Dr. Rachel Manber, Professor at Stanford University School of Medicine, Director of Sleep Health and Insomnia Center, and co-director of the Center for Sleep and Circadian Sciences. And Dr. Joel Reiter, a Senior Lecturer of Pediatrics at the Hadassah Hebrew University Medical Center and the Director of the Hadassah Sleep Center. Presenting the articles today will be Dr. Marwa Ibrahim, Sleep Medicine Fellow at the Icahn School of Medicine at the Mount Sinai, New York. And before we begin, I would like a couple of reminders for our audience. We want this to be a lively and interactive session, so we encourage our audience to be involved. We welcome your questions and comments during the webinar. To keep things running smoothly, please remain muted and feel free to type your questions or comments in the chat box, and we will read it out to our panelists to address as time permits. Also, please note that this webinar is being recorded and the recording will be made available and posted on the ATS website. I would now like to turn things over to Dr. Ibrahim to begin her presentation. Sorry, you're muted, Marwa.
Hello, everyone. Marwa Ibrahim, Sleep Medicine Fellow here at Mount Sinai Hospital. And we're going to review melatonin. Is it the beauty or the beast? So melatonin, it's a dietary supplement, and thereby it's not regulated by the US FDA, requires no prescription, and despite insufficient evidence in this country and others, it's widely used as an over-the-counter sleep aid. The amount of melatonin that's actually present in these over-the-counter supplements can vary drastically. A recent examination showed that 25 commercials, reviewing 25 commercial supplements, showed that the actual melatonin quantity ranged from 74 to 347% of the labeled content. And the incidence of melatonin-related ingestions that's been reported to the Poison Control Center has increased significantly, about 530% from 2012 to 2021, mostly among children below the age of 5. So we'll start with our first question is, what is the trend of self-reported melatonin use? The first paper that we're going to be looking at was published in JAMA, and they reviewed the trends in the use of melatonin supplements among US adults, and they looked at this time range between 1999 to 2018. They took data from the National Health and Nutrition Examination Survey, the NHANES, and they basically looked at these surveys from non-institutionalized US population between 1999 to 2018. They did exclude participants that were under 20 years of age or those who did not have available dietary supplement data. Because the recommended dosage of melatonin is typically does not exceed 5 milligrams a day, they also evaluated the prevalence and trends in use greater than 5 milligrams, but they excluded those when the exact daily use was not provided. So all the participants provided written informed consent, and they obtained the data on the dietary supplements using the past 30 days. And the daily dose used when taking the supplements were collected actually through in-home interviews. The supplement containers were actually verified was verified by interviewers for almost 94% of those who were self-reporting to use melatonin. So the participants actually had to show their containers. The statistical analysis of the paper, they actually used the weighted prevalence and 95% confidence intervals of the melatonin use in the overall sample, and it was computed for each survey cycle across sex and age categories. The prevalence and 95% confidence intervals for the dosage that was over 5 milligrams per day was also calculated separately. The p-values for the linear and quadratic trends was calculated using linear regression modeling with the survey cycle as a continuous variable. And to determine if the trends was varied by demographic characteristics, the interaction effects were also assessed using weighted logistic regression. So this is a busy table that I basically extracted from the paper, just to kind of make it a little, it's busy, but it essentially shows the reported weighted prevalence of the melatonin use. And you can see here by gender and age group. So one of the interesting findings is you can kind of appreciate the overall reported weighted prevalence increased from about 0.4% in 1999 to 2000 survey cycle to 2.1% in the 2017 to 2018 survey cycle. And the increase, as you can see here, it started really about in the 2009 to 2010 survey cycle. This is when things really started to take off. And as you can see, I know it's a busy slide, but one thing that was appreciated was that the trends were similar across gender as well as the age group. The p-values, as you can see here, that were listed as NA, was when one or more survey cycles had no observed outcomes. So they did not list, they did not include that. So this is a graphic version, a graphic depiction of this the previous table that I just showed. And again, we're showing the reported weighted prevalence of this overall melatonin use, which you can see is in forest grain. And side right next to it is the use that was over 5 milligrams a day in orange. So as you can see, among US adults, the reported prevalence of melatonin supplement consumption significantly increased from the beginning of their study, 1999 to 2000 survey cycle, to the 2017-2018 survey cycle. And this was across all demographic groups. Now, you can see the trend for the greater than 5 milligrams a day was lower. It remained very low, but as you can see, the prevalence also increased over time. So there were some study limitations, and they included that. So it was self-reported use, although, like I mentioned, the supplement containers were verified in nearly all participants. Because the small number of melatonin users in some subgroups, the results of the previously mentioned stratified analyses should be interpreted with caution. And the reliable estimates of the trends in melatonin use across racial and ethnic groups was not provided. And additionally, the reason for the use was not available in these survey cycles. So now we looked at the adults. What about kids? So this is a paper that was published in JAMA Pediatrics. And this looked at the parental reported melatonin use among US children and adolescents. So this was an online questionnaire. It was completed by parents of children aged 1 to 13. And the data was collected via convenience sampling from January to April 2023. The questionnaire included demographic characteristics and the following questions. So the first one is, has your child taken melatonin in the last 30 days? If the answer was yes, these were the follow-up questions. How many days per week does your child take melatonin on average? What form is the melatonin? What's the brand? On a day when your child takes melatonin, how many milligrams do they take? What is the reason your child takes melatonin? What contributed to the decision to give your child melatonin? How long has your child been taking it? And has your child experienced any side effects? So these are some of the results from this particular paper. And you can see here, this is the this is the melatonin prevalence across the specific age groups. So we have here 1 to 4, preschool, the school age, and the preteen. One thing, so they analyzed this data and classified them based on the age groups. And as you can see, the melatonin consumption was higher in school-age children and preteen overall in the past 30 days. Another thing is that you can appreciate here is that the melatonin dose and the duration of the use increased significantly across age groups. So you can see here, it went from the median for the preschool children was about 0.5 milligrams, and that went up to 1 milligram in the school age, and then that doubled for the preteen for the median dose. Now, in terms of the duration, again, similarly, an increase from 12 months in the median to 18 and 21, which is a pretty long period. One thing that you can see here is the timing of the melatonin administration was fairly consistent, which was about 30 minutes before their bedtime. Another finding that they saw was that overall there was a bimodal distribution of the frequency in which the melatonin was most often administered, either 1 day per week, majority 1 day, or 7 days a week. There was an interesting finding here. One thing is that across all the age groups, the most common form of melatonin use was gummies, 64.3%. And this was followed by chewable tablets, and then smaller proportion were using pills and liquid. And this is kind of makes sense because specific melatonin forms and preparations are more child friendly, and this could be a factor in the increased use among the pediatric population. And now, like I mentioned earlier, the duration of the use was pretty long, often greater than a year, in the absence of any long-term safety of melatonin in the pediatric population. Now, the next question that we wanted to look at is, well, okay, I showed you the trends in adults and the trends in kids, but what safety risks have been posed that has been related to melatonin use? So this paper, this was one of the morbidity and mortality weekly reports that looked at pediatric melatonin ingestions in the United States from 2012 to 2021. This was a cross-sectional study of the pediatric melatonin ingestions that was actually reported to the U.S. Poison Control Centers, and it included all closed cases of single substance melatonin ingestions involving children, adolescents, and young adults under 19 years old. Now, a closed case is actually one where the Regional Poison Control Center determines that there is either no follow-up or recommendation required, or no further information on the case was available. And again, this was the time period that they looked at this, and they were able to get aggregate national data from the National Poison Data System. They did exclude non-ingestion routes of exposure, information requests, exposures with unknown age, and non-human exposures. So this is one of the tables in this paper, and this here shows the demographics and the clinical characteristics of these reported pediatric melatonin ingestions. So during this period, 2012 to 2021, a total of 260,435 pediatric melatonin ingestions was reported to the poison control centers. Now, this actually represents 2.3% of all pediatric ingestions that was reported during that same period. You can see here the majority of the ingestions was unintentional. It involved males for the most part, and the age group was 5 or below, and the exposure site was usually at home. So this is this is the same table continued, and you can see here this is the clinical effects. So most children, about 82%, were asymptomatic. Of those who did report symptoms, they typically involved the GI cardiovascular, and CNS systems. And the majority of those ingestions were managed on site. So as you can see, some ended up having to go to the hospital, but majority did not. Now, among the 27,000, so about 27,795 patients who did receive care at a healthcare facility, so about 72% were discharged. 15% were hospitalized. 1% actually did require intensive care unit. So you can see here that among the melatonin ingestions, 1.6% did result in more serious outcomes. And 5 children did end up requiring mechanical ventilation. 2 actually died, and both deaths occurred in children under the age of 2. One was 3 months old and one was 13 months old. And both of these deaths, these ingestions did occur at the home. One ingestion involved intentional medication misuse, and the reason for the other is unknown. So this is not just like a benign supplement. Can see here in this figure, this is the rate of the pediatric melatonin ingestions reported to the poison control. With it on the y-axis is the number of ingestions per 100,000 U.S. population. So as you can see, the annual rate of ingestions per 100,000 U.S. population. Just want to make sure I didn't miss anything. Did they mention the amount or the dose of the melatonin ingested? For if you're referring to the ones that died, I did not see that in the paper. Yeah. Okay, I'll just should I keep going and then we'll answer this? Maybe just I'll just keep going and we'll return to the chat. But I'm glad that people are engaging. So you can see the annual rate of ingestions did increase over the 10-year study period. The number of pediatric ingestions increased 530% from 2012 to 2021. And interestingly, the largest yearly increase occurred from 2019 to 2020. And this kind of coincided with COVID. And unintentional ingestions were the primary drivers of this increase. And this could be related to increased accessibility of the melatonin during the pandemic, particularly, or increasing sleep disturbances as a result of just having more exposures. So this here is showing the pediatric melatonin ingestions, and the ones you can see here, those that were hospitalized and those that had more serious outcomes. So more serious outcomes was classified as those who had a moderate effect, which includes systemic symptoms that did require intervention, not life-threatening. And an example was a brief seizure that resolved with treatment, or a high fever. A major effect was life-threatening symptoms and death. So most hospitalized patients that they looked at were teenagers with intentional ingestions. And the largest increase in hospitalization was children 5 or below with unintentional ingestions. So the big takeaways from reviewing these papers is that widespread melatonin use across developmental stages may actually suggest an unrecognized prevalence of pediatric sleep disturbance, and this deserves accurate diagnosis and effective treatment. These estimates definitely raise safety concerns, especially since the actual content, like I mentioned, in these marketed supplements that are not FDA regulated may be significantly higher than the labeled content. And the available trends of melatonin use, whether it's in adults or the pediatric population, it warrants stronger evidence regarding the long-term safety of melatonin supplementation. And clinicians should be discussing this with parents, the factors that can be associated with sleep difficulties, and effective behavioral strategies that they can use. So to start off our discussion, the guidelines by the ASM do recommend cognitive behavioral therapy as a first-line treatment for insomnia. So I guess the first question is, how do you perceive the role of pharmacotherapy and specifically the use of melatonin in this context?
Thank you for the great presentation, Dr. Ibrahim. And please write your questions. I see people already began doing that in the chat box, but maybe Dr. Conroy would like to start, and then we'll continue.
Great, thank you so much. My name is Deirdre Conroy. I am a clinical sleep psychologist. I work only with adults, so I would very much appreciate those that work with the pediatric population. So yeah, the AASM suggests cognitive behavioral therapy as our first line treatment. And sort of, I think that my first comment to this question is that it depends. One, pharmacotherapy can be quite helpful at the initial stages of working with an individual with insomnia, because there's a lot of exploration of cognitive distortions and habits. And when the anxiety is too high, it's very difficult to kind of get into those types of strategies. So it can be helpful to what you do. I think also that the other piece of this is that cognitive behavioral therapy for insomnia is an interaction with the patient. You're having a conversation and educating the patient about sleep. And I fear that a lot of that is not happening in lots of the situations in which people are choosing to use high doses of melatonin for doses that aren't recommended for longer durations. And this could also be said for other pharmacological agents out there, that there isn't enough discussion between patient and provider. And I can say more about that later. But so I feel it depends, and hoping to hear from others. Thank you.
Dr. Manber, maybe the same question.
Sure. Maybe I can also start with a question. I really searched the literature. I've observed an increase, a trend towards prescription of melatonin among adults at doses of 10 milligrams or more. And I was trying to find, is there any research on the efficacy of 5 versus 10? Why is there such an increase in 10? And I also were not able to find any guidelines that say that you should actually prescribe it at 5 milligrams or less. So I was wondering if any of the experts here can comment on that before I answer the question about the insomnia treatment in general.
Dr. Reiter, you want to weigh in?
Okay, so I'll say a few things. For one thing, I think most of the patients that treat us as sleep specialists have already been on some form of pharmacotherapy, because the general physicians will usually not start cognitive behavioral or even get in that direction, and they're usually not sure of how they can even do it. So usually we get the patients that to at least some degree have already failed some degree of pharmacotherapy. Some of them have tried melatonin and some of them haven't. And now in Israel, so we have an advantage because it's not available over the counter, but it is available for the elderly, for instance, in a slow release formulation of 2 milligrams, because studies from the beginning of the millennia showed that at older age, the pineal gland that degenerates and then melatonin levels go down. And to some of these people, melatonin will help. So a lot of them have already come after they've tried. I often find that patients will try the lower doses, and then if not, sometimes someone will tell them to increase. I'm not sure there's studies about the higher doses. I know that in children, the studies are not very convincing, and many of the studies show that if you've tried 5 and that's failed, the chances of 10 being helpful are not that good. I think that's it more or less. Was there anything else asked?
Where are the guidelines for 5 or less?
So I'm not sure there are formal guidelines that say exactly what doses are. And then again, one of the problems is if you're taking over-the-counter medications, then nobody really knows what's inside those gummies or bears or tablets or whatever. And when it says 2 milligrams, you don't really know what you're giving.
Absolutely true. The reason I'm asking that is in the paper, the Dr. Ibrahim Marwa has presented, they said because the recommended dose is 5 milligrams or less, and they did provide a reference, and I am eager to find a reference for that, but that's fine. So coming back to the question that you have posed about treatment of insomnia with CBTI, so and the role of medications and melatonin. So I treat both adults and children. And whereas CBTI is very effective across ages or variants of pediatric versions of CBTI that are not exactly the formulation that's done in adults, there are situations in which for both children and adults, there is a role for medications. For example, when there is an acute recovery from surgery of other kind of life situation and crisis, when there's a travel associated sleep disturbances. The problem is not that medications are bad. The problem is that when they are used as needed, and the as needed becomes every night for years, then it becomes a problem. So I will stop at that.
Thank you. Before moving on, there was a question asking why is melatonin over the counter in the US and not in other countries or vice versa. Dr. Licis, as a ASM representative, you want to comment on that maybe?
Right. So I think, like we've been discussing, I think there's some unanswered questions about, melatonin and safety and different formulations. As you know, it's not FDA approved, but there are, I guess, some mitigating factors, which is, trying to use at least brands that are United States Pharmacopoeia verified or pharmaceutical grade. I guess with regard to the difference in regulations comparing the United States and other parts of the world, I guess I don't feel as that, it's just different approaches. I can understand some of the reasoning as to why melatonin, could be more restricted given, some of the concerns about the actual quantity, the differences in purity. And, I think we can discuss more how there's definitely, there could be a role for more regulation. So, yeah, it's just a different approach. I guess I can speak directly to, the other parts of the world, how it's regulated there. But, with regard to the United States, at least, it's not currently FDA regulated, but we could, some may argue that it should be, so.
Anyone wants to add to that?
So I think one of the reasons it's regulated in Israel is because one of the companies that initially brought it here made synthetic melatonin, so that they had an incentive to try and put it into the health path as a formal medication, whereas in places where it started off as a natural supplement, it's kind of hard to later change that and turn it into something that is regulated. I think it might have been just the historic thing.
Okay, and maybe to follow up on given melatonin and who we give it to, Dr. Reiter, maybe you can start off. Where do you see the role of melatonin in pediatric populations? I mean, there are some guidelines. I don't know if everybody's familiar with them, and specifically in other populations, healthy kids also as well.
Okay, so I'll start off by saying that I don't see a role for melatonin in healthy children. I think it is not the right solution. I think it might be something for a very short period of time, but other than that, you're putting a Band-Aid on a problem and not solving it. And that's what I usually tell parents that come to me. I do find that it has a role in certain specific populations, such as children with autism, where you're kind of with your back against the wall and you want to treat them many times with some sort of medication. And then when you compare melatonin to the other sleep aids that are available or can be given, or other medications that have sleepiness as a side effect in children, then melatonin is relatively easy and safe. And then we go by the synthetic melatonin. So we try not to use the natural stuff, but use something where you know exactly what you're giving and what it's going to do. I have arguments with the companies that make it about how long and how much of a benefit it will give, and whether or not we need to put the behavioral aspects first before the melatonin. And what I usually tell the patients is that definitely it has a primary role.
Thank you. Anyone else?
I guess with regard to typically developing children, if there is a suspicion that those children are, have a delayed circadian preference, that would be a circumstance in which I would consider melatonin, to help, set their circadian rhythms earlier, like a lower dose a few hours before bedtime. But yeah, otherwise I agree. I don't favor it for typically developing children.
Yeah, I will say that I do separate insomnia from delayed sleep phase, and in delayed sleep phase in the teenagers, then I do use it more often. But as an insomnia medication in the younger children, I try to avoid it.
Right, and I think from what we saw in the timing of melatonin dosage and the age, most of the children got it as a sleep supplement and not as a circadian adjuster. Dr. Conroy, you wanted to comment?
Oh, I was just going to also echo that. I think the message that melatonin as an assistance for a circadian problem versus an insomnia gets lost, and there's some utility in a circadian picture and maybe not as much in an insomnia picture, but I don't think that the general public has knowledge about that. And I think that gets lost. So that's something for us to really educate our patients and other providers about.
If I can take a ride on what Deirdre just said, if we talk about science, there is a very strong science base for the chronobiotic effects of melatonin at very, very low doses, given at specific times across the estimated curve of the individual. The evidence for efficacy of melatonin as sedative is very, very poor. There is a huge, monstrous meta-analysis of all medications for sleep that was published in the Lancet, I think about a year ago, or maybe two by now. The efficacy of melatonin is not there. There's no evidence based on the data that they reviewed. There's another meta-analysis that looked at the efficacy that similarly concluded, just of specific melatonin, that similarly concluded that it's not effective. There is a small signal for older adults, and there's a small signal for pediatric. So I think it underscores what Deirdre is saying. We really need to make a big distinction in discussing melatonin as a sedative versus a chronobiotic in terms of the science behind it. And somebody asked here a question about slow release versus extended release. I did a little bit of a deep dive into that about a year ago. And it looks like the slow release gains you total of 2 extra hours of it being in the system. It's not a huge difference. I was very surprised to see that.
And I guess just to comment a little further, when we're discussing specific populations, say children with autism or neurodevelopmental disorders or other populations of children for whom it's suspected that melatonin levels may be low, in that case, then there is some data in some studies showing, some potential effect on, melatonin taken close to bedtime, more as a sedative doses, but just, that's specific to those populations, though, it seems.
Do we have any more questions there? The slow release, and I think we already answered the dangers of taking it chronically. Besides the mortality report, we don't have the data as far as I'm aware, right? Anyone else?
The dangers of chronic, I think the question came after I spoke, so I think the person who's asking was wondering, why did I say that when medication, sedative hypnotics are taken long-term, it's a problem. So the word danger is way too strong. There is evidence about side effects of, first of all, there's evidence that over time there's built tolerance and psychological dependence, and taking the medications have some side effects that are particularly dangerous among older adults. So the recommendations against use of sedative hypnotics are really coming for older adults. I would say there is likely and not understood individual differences on who will and will not develop tolerance, who will or will not develop side effects. So I think that is a very much an open area. I don't think that there's no place for sleep medications, even chronically in some cases. But I think we really don't know more than we know.
There were a few studies that tried to look at growth and sexual development in children that were getting melatonin because supposedly it could have an effect there. And the longer studies were not very long. If I remember correctly, they were up to 1 year and they didn't show any effect, but that's not very, very convincing. And I think the bottom line is nobody really knows what happens in the long term if you take melatonin for a very, very long time.
There's a couple studies I want to say went up to about 3 to 4 years, no clear effect on pubertal timing, but I know that's still something under investigation.
Okay, so maybe this would give good opportunity to Dr. Ibrahim mentioned this, and I know we have also described this trend of increasing supplement use in the recent years, and obviously COVID pandemic had some role in it. But I was surprised to see that the uptake began in 2010. So why do you think we're seeing such an increase in the over-the-counter supplement use?
I'll just share anecdotally, I have received more referrals in that time period, so post 2010, for my patients whose doctors are weaning them off of their hypnotics, mostly BZRAs, and they're trying to supplement with melatonin. And so I'm curious if there'll be studies on that interaction. So less BZRA use, more without much education, melatonin use.
Okay, there was a question.
It says interesting, if I may comment, that 2010 is when the British Pharmacological Society, that was the first society to come up with warning against the use of sedative hypnotics medication. So, and specifically identifying CBTI as the first like treatment for insomnia. And that was 2010 paper by Wilson and on behalf of the British Pharmacological Association. So I don't know if it has something to do with it, but it was the gist of the time.
And speaking of CBTI, we all kind of understand and agree that CBTI is the recommended treatment, but at least where we are practicing, we have a big shortage of CBTI, access to CBTI or providers who can provide CBTI. How do you think we can address it, both as a society or sleep specialists? Dr. Licis, maybe you can start off.
Yeah, so CBTI, I agree, should be first line whenever possible. And, you know, like we said, it's just access is an issue, you know, in many places. There have been studies showing that there are online forms that can be effective for CBTI. There's some online programs. And then there also have been studies showing that, you know, people with, you know, different level of cognitive impairment can, you know, in many cases still benefit from CBTI. But I do think the limiting factor may be access. But in addition, there are some people for whom, you know, their biology is just different, you know, regarding their sleep-wake neurotransmitters. So melatonin levels may be low in some populations of people. And that's when sometimes CBTI, you know, may be not quite enough to address, you know, all the causes of insomnia if, say, they have low melatonin.
Dr. Conroy or Dr. Manber?
Deirdre always says what I'm going to say. So
No, you start first, Rachel. You go first.
So I actually would say that indeed there is an issue of access to trained providers to do that. There is an increase in the number of providers in the United States. There is luckily a way to increase access to therapists delivering CBTI through 34 states have created a SIPAC, and that is an agreement across states that therapists can practice across state borders. And so there is a huge area in the United States where availability is there, particularly given evidence that telemedicine CBTI is not inferior to in-person CBTI. And so there is potentially addressing areas that don't have providers, rural areas, that can be enriched as this SIPAC is growing, and it is growing. I know New York State is one of the states that the registration already passed, so it would join the pact, and so that is very important. So the availability of telemedicine and some ways to do psychotherapy across borders is a good step in the right direction. Of course, there is the apps, and the apps have may work very well for many people. They have... Sorry.
Você vai ficar aí, não vai, Flávio? Você vai ficar aí, né? Consegue manobrar?
He's
Eu
mute.
preciso subir pro consultório.
Can you mute him?
Trying. Miriam?
Yep, I am muting him.
Okay, thank you.
He's muted.
Okay, so basically what I was going to say is that the apps definitely have a role. The problem right now with apps is that, as we all know, the model of having the apps being prescribed by physician is no longer available because the company went under. So there was one app that was FDA approved for prescription by physicians. It was bought by a company that's using it internally rather than making it available for the general population. And at present in the United States, the apps are not being marketed direct to consumers. They are marketed to organizations. And so access to apps is, although they could increase access theoretically, A, insurance companies don't cover them, and B, there isn't that much access to them. So I think finding smart ways to combine therapists and apps could be potentially a good way to go.
Thank you. Someone asked about, is there evidence about Rameltion as being more effective in hypnotic aspect than the natural melatonin? Anyone can comment on that?
Melatonin is more potent, and it has a longer duration of action. So I guess sometimes it can be considered in certain populations for whom it's suspected that melatonin levels may be low, like people with neurodevelopmental disorders, if melatonin itself isn't effective.
Thank you. Next question I want to ask about, so we basically agree that the melatonin might be dangerous, and there's some evidence that is effective in some specific occasions, but not in many others. How can we educate the public, where we as societies, the ATS, the ASM, how can we go about it, do you think, Dr. Licis, maybe?
Yeah, so I think you're right. Working with the societies is a good way to put the word out. I think also reaching out to the public in other ways too. I do feel like there's some under recognition by the public about the dangers of melatonin. I think we need more safety messaging. Melatonin should be treated like a medication and locked up like other medications. I think working also with the general pediatrician and other health organizations outside the sleep field, I think would also be effective, to put the word out. Yeah.
Can I comment on that, please? Hello?
Yes, please.
So there was a study in Canada about 5 years ago that showed that of 18 brands tested, not one was better than 80% accurate. And so there really is a bit of a scam of what people are getting when they think they're purchasing melatonin over the counter in a pharmacy. There are recent reports of cannabis being added into melatonin, and no one knows that that's been done. And there have been 3 deaths of little kids taking melatonin in Canada. In general, my philosophy as an older physician is that you use a hormone if there's a hormone problem. No one uses insulin to lose weight. If, in my view, melatonin is an agent to control body clock, I use it often. We measure people's melatonin who we think are phase-delayed, and when appropriate, we treat with pharmaceutical-grade melatonin, which I've been required to import from the UK for about 25 years, and I got a license from the Canadian government. And so we're pretty rigid. If you want to promote sleep, the right agent, particularly in kids, is tryptophan. If you give an increasing dose of tryptophan, most kids who have just a straightforward sleep problem and you're choosing that route of using some agent to help them, is, to my mind, a much better and safer option.
So maybe this will be actually a segue to our last topic, and we can have all the panelists comment on that. How should we go about it? Should we promote regulation of melatonin in the US? Should we stop the over-the-counter use? What do you think? And we didn't discuss the CBD content, but the paper was very recent and really mind-boggling that there was CBD in those gummy bears. So again, do you think melatonin should be regulated in the US? And what steps should we do?
So maybe I'll start as the outsider from a country where it is regulated. Yes, I think the US need to regulate it because I have too many patients that get their natural melatonin from the United States and import it to Israel. So yeah, I think the US need to regulate it, and I think maybe the ATS should put the pressure on the FDA to include it as a regulated medication.
I would definitely concur with that. I think, no one goes to the shop to get insulin to lose weight or thyroid hormone to lose weight. You get it on a prescription. I don't understand why melatonin is different. The reason is that for a long time it wasn't as well recognized and people thought it was just innocuous, but it's not.
So yes, it should be regulated. I think these studies, highlight very well how the dosing is just so unreliable among the different brands, and even from lot to lot, it's not acceptable to have melatonin dosing either so low or up to 5 times higher than what's reported. So I say, I agree. Yes, it should be regulated.
Anyone else wants to weigh in? Or are we all in agreement and the next steps will be writing up the recommendation to the FDA? Yeah. All right. So I would like to thank our expert panelists on behalf of the ATS SRN Assembly, Dr. Conroy, Dr. Manber, Dr. Licis, and Dr. Reiter, for your insights and the perspective you've given us. And thank you, Dr. Ibrahim, for your excellent presentation. And thank you all for taking the time to join us today. Hope to see you at the next ATS SRN Journal Club and in the upcoming ATS meeting in San Diego in May. Thank you very much.